Okay, and we're back for newborn assessment. There is a newborn shift assessment video that sort of does an abridged version. This is a more thorough, comprehensive exam when you're meeting this baby for the first time. They're all John and Jane Does. They are not verbal. They cannot tell you if something is wrong. And there are a lot of things that can go wrong in development. They mostly don't, but we still have to look. So this is a more thorough assessment. Pause it where you need to pause it. But we're going to talk about everything from initial general appearance to, and we're going to go through all the systems. So this is your comprehensive exam. You start with overall appearance, not really different from how you assess an adult patient. You go from airway, breathing, and circulation, which is your vital signs. And then, you do some general measurements. And then we start to go in a systematic way from head to toe, unless we find a problem. And then we do a more focused assessment, really very similar to how you would assess an adult. So general appearance, we start with vital signs. And you can refer to the other video for help with how to listen, where to listen. But basically, we're just going to talk about normal. Normal heart rate in a baby is 110 to 160. It's really fast. It's one of the hardest assessments for students to learn. And it sounds like shoo, 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 shoo. It's really, really fast. But practice, tap it out if you have to. It should be regular. And this normal range is for a baby who's calm and quiet. If they're really excited, it can go higher, the heart rate. If they're really passed out cold, it can go a little lower. They can have a low resting heart rate, and it might not be too clinically significant. So you want your baby ideally in a quiet, alert state. Respirations 30 to 60 are normal. Remember that babies are belly breathers, and they are periodic breathers, meaning that they don't breathe regularly or rhythmically. They sort of do this funky pattern. It sometimes freaks parents out where they breathe. They'll take 3 or 4 rapid breaths, have a little pause, breathe normally for a couple of breaths, and then do it again. It almost looks like Cheney Stokes looks in an older person. It's just a sign that they're new at it. And it's perfectly normal as long as they're in that 30 to 60 range and they're not showing any other signs of respiratory distress. Temperature. We do it as an axillary because rectal can cause perforation, and your normal range is 36.5 to 37.5, which translates, that's Celsius, translates into 97.7 Fahrenheit to 99.5 Fahrenheit. Remember, when you're counting a rate, heart rate, or respirations, you count for a full minute. We typically don't do blood pressures on normal newborns. It's something you would do if there were a problem, if you had a heart murmur or a baby didn't look vigorous. And pulse ox isn't something we do routinely on newborns, although we will do it if the baby is showing any signs of distress. And you would put the sensor on the baby's right hand, typically, if you needed to do that. Now, weight and measurements. These are some normal numbers. Not that you should memorize them, but get familiar with them. What you would normally do is you would weigh your baby and plot it on a scale for gestational age. So the variations are actually AGA, which is absent from this slide, but that means appropriate for gestational age. You can also have SGA, which is small for gestational age, or LGA, large for gestational age. So normal, we're expecting somewhere in this 5 pounds 8 ounce to 8 pound 13 ounce range. Some babies are bigger than others. Some families grow them big, some families grow them small. Not a cause for concern as long as they're in this range that's normal for a term baby. Preterm babies should be plotted on their own graph because their norms will be different. Things that you might want to remember is that it's normal for babies to lose up to 10% of their birth weight. You want the birth weight to be as accurate as possible to make sure that the baby is not losing too much. You can reassure your breastfeeding moms, and that'll be a separate video, breastfeeding. Every mom wants to know if she's making enough milk. Tell them right up front, we expect the baby to lose 5 to 10% of their birth weight in the first 3 to 4 days. They'll regain it by 2 weeks of age. But they're sort of born with extra fluid on board. So it's normal for them to lose some weight. For length, again, I don't want you to really memorize this, but the roundabout size for a baby who is term is 18 to 22 inches or 46 to 56 centimeters. And when you measure enough of them, you kind of get a pretty good ideal for whether or not they're in the ballpark. If they're smaller than 18 inches, you start to worry if there was some IUGR going on. But I have had some babies bigger than 22 inches who are perfectly healthy. Head circumference. These are your norms, 12 and a half to 14 and a half inches or 32 to 37 centimeters. That's an indication of brain growth a lot of times. So we want to be careful with head circumference. Sometimes when our baby is SGA or small for gestational age, what's going on is brain sparing IUGR. So the head circumference will still be in this normal range, but their weight might be lower. It's because their brain kept growing and the rest of them did not. And that means that the body was prioritizing, which it does because it's a smart machine. Then we have chest circumference. It should be 1 to 2 centimeters less than the head. Abdominal circumference is going to be roughly equal to the chest. It may be a centimeter smaller. But you guys did this in lab. I'm not going to beat it to death. You measure the head circumference right where the eyebrows are. So I'm not loving this slide as much, but right across the eyebrows, usually where you measure head circumference. And that should be what we want to see is we get a baseline. We want to make sure that the baby's brain is growing. So at subsequent visits, and you'll learn this about this more in peds, you want to make sure that the head circumference is growing on a normal curve. Chest circumference, we do at the nipple line, and then abdominal circumference, we do just above the umbilical stump. And here it's like just below that little landmark. But we normally like to do it just above the umbilical stump. And it's important to get a good, accurate abdominal circumference because you may have to measure it later if it looks like your baby's getting distended. And this is a baby on a scale. Normally, I don't pat it with a paper towel. I'll take a warm receiving blanket and put it down there. They like it better. But you see the baby doesn't have any clothing on. And we want to get an accurate birth weight if we can. A lot of times parents are really funny. They'll ask you things like, how much does a baby weigh? And the baby's been skin to skin for 45 minutes and never left the mom's chest. And I'll say, well, we'll find out in a little bit. So make sure that when you do that weight, in the absence of any kind of problem, have somebody nearby with a camera to get that picture because it's something that parents really do love. And that birth weight it becomes part of their birth story too. Estimation of gestational age. Now, in most cases, we don't really do formal assessment of gestational age anymore. We used to do like a Ballard or even a Dubowitz. Dubowitz is like a really extensive scale of tests that you would do, little assessments to see how old gestationally this baby was when it was born. Now it's not as common. Most women have good dating. Either they know when their last menstrual period was. With the invention of home pregnancy tests that are super sensitive, most women know very early in pregnancy that they're pregnant. They get an early ultrasound. But if you're not sure, if your baby looks like mom didn't have good dating, for example, you think you're expecting a baby at 39 weeks and it comes out and it looks preterm to you. It looks small and it's covered in vernix and maybe doesn't have great tone, or you see a lot of veins, whatever. You can do a Ballard. You can do a full-on gestational age scale. And it assesses, we're going to look at the form in a sec, and we'll play with it some in class and see how you do. But the take-home points are that baby looks different, whether it's term, preterm, or post-term. A term baby is all curled up in the so-called fetal position, and it ran out of room in utero. It was cramped in there, it was curled up, and it likes it that way. It's going to resist you trying to straighten its limbs. So resistance to extension, and when you let go, it's going to recoil. It's going to come right back. So if you try to stretch the leg's going to curl right back up again. If you try to stretch out the arm, it's going to curl right back up again. These babies have well-developed creases and folds. So the creases that I'm talking about, you would see them in palms of the hands, really the soles of the feet. When you see a baby that has lots of crisscrosses all over the sole of the foot, that baby's most definitely term. We also see changes in the external genitalia. The labia majora get bigger with gestational age. So a preterm baby will look like the labia minora are bigger. But a term baby, which is what we're interested in right now, the labia majora will cover the labia minora. Little boys will have more creases in their scrotum. Those are called rugae. Thicker skin. So this is a baby you can't see right through the skin to all the veins. The skin should be pink and not red or shiny like a preterm baby. Babies who are term will have some vernix, but it will be mostly in the creases. You'll see it in the folds of the neck. You'll see it in the armpits. You'll see it in the back of the knees. You'll see it in the elbows. But those preterm babies or even like early term babies, 37 weeks or so, will have more vernix. And there is firmer cartilage. So if you were to say bend the ear, in a term baby, it would resist that bending. It would feel stiffer. It would feel like it had a little more starch in it. Whereas preterm babies, that cartilage will be softer. And I'll talk about that more in a second. So preterm babies in general have more flaccid tone. They look a little more froggy. They look more relaxed. They don't have that resistance to extension. They sort of let you stretch them any which way. So we do things like the scarf sign where we pull their arm across their neck. And if we can go really far and all their joints are bending, then we know we're looking at an earlier baby. Same thing with the hips and knees. Those joints will be much more flexible. They have thinner skin. And that's why the vernix is important to protect that. So the thinner skin, when you have a very, very preterm baby, 24, 25 weeks, some of you have seen those babies in NICU. Their skin looks red. It can look shiny right at delivery. And it's very, very sensitive. You'll see veins right through it. As they get older, that skin gets thicker. It gets more opaque, meaning you can't see through it. Preterm babies also have visible veins because of that thin skin. They haven't developed creases on the soles of their feet. The rugae in the scrotum are not developed well. The labia minora, like I said, look bigger than the labia majora. It's almost like they're inside out. And there's, when you get towards like 34 weeks, 35 weeks, 36 weeks, there's more vernix. It'll disappear a little bit later. Their cartilage is softer. So when you bend the ear, it's going to like kind of let you bend it really easily. What's important to remember about that is that affects all the cartilage in the body, including the cartilage in the trachea. And so we have to be really careful with a preterm baby's airway. Now let's talk about post-term, the babies who are overbaked or overcooked. You will hear nurses refer to them that way. They look cracked and leathery. There might be meconium staining. There's more of a chance that they've passed meconium in utero, and they will have no vernix or very, very little vernix. And the reason that they have all that cracking is because the vernix disappeared. The vernix serves like a protective function. So here's the Ballard scale, and what you would do is just assess your baby for each one of these things. You can look at the skin. Lanugo is fine hair, and when we assess skin, I'll talk more about that. But preterm babies are kind of hairy babies, especially when they're at that when they get to be like 30 weeks or so. But then, as they approach term, that lanugo falls out. And by the time they're term, they're mostly bald. They'll have scalp hair, but not really a lot of that back hair and neck hair and face hair. You see a lot of lanugo in 34, 35 weekers. It kind of goes all the way down on their forehead towards their eyebrows. Plantar surface. These are when I was talking about the creases. As I said, you get more creases as you get older. You can look at breast tissue. So that fatty tissue doesn't really develop until later in gestation. And so, you would look at development of the areola in the breast and look for some fatty tissue underneath. Eyes and ears, that, cartilage that we talked about, and then the genitals, male and female. We can play with this in class a little bit more. But let's go to newborn reflexes. And for this, I chose a lot of these separate little YouTube videos because I think some of these tests are a lot easier to understand how they work if you see somebody do them, as opposed to hear someone talk about them or see text on a slide. So let's start with sucking and rooting. So you see this doctor, he's just so gentle. So the sucking reflex, baby's got the pacifier. Babies will suck on just about anything that comes in their mouths if they're healthy. So he's eliciting the suck reflex. Now watch, he's going to take the pacifier out in a sec, and he's going to stroke the baby's cheek. Come on, Doc, you can do it. There he goes.
By just stroking the side of the face.
Now just watch the baby's head.
Seek for that.
There he goes. Okay. And that's the rooting and sucking reflexes. So now we're going to go on to grasping reflexes. And most of you have done this in clinical, and so you're a little bit familiar with it, I hope. These are sort of primitive reflexes that the baby can use if they feel like they're falling or if something gets in there. There's the palmar grasp. Okay, that's the one that parents love. We talked about it. And here's the plantar grasp. The toes curl in when you press on the bottom of the foot. So let's get rid of that one. And now we're going to do the Moro reflex. If the palmar grasp is the one parents love, the Moro reflex is the one they hate because you have to make the baby feel like it's falling to elicit this reflex. And here he is, so cute, not suspecting a thing. And boom, he feels like he's falling. You see those arms come out. They're going to come to the midline a little bit. And now he's going to do it again. So mean. Oh, tears your heart out. But baby's fine, didn't actually fall. But you saw him bring his arms to the midline. They kind of fling their arms out and bring them back to the midline. And next we're going to do the tonic neck. Let's do that one.
Tonic neck reflex. When baby's head is turned to one side.
Oops, sorry about that. Let me get back to where we were.
Tonic neck reflex. When baby's head is turned to one side, the arm will...
I'm going to try and get that bigger for you.
On that side stretches out
just
and
take
the
a look.
opposite arm bends up at the elbow. This is often called the fencing position. This reflex lasts until the baby's about 5 to 7 months old.
So let's see that again, because it was hard to see.
Tonic neck reflex. When baby's head is turned to one side, the arm on that side stretches out and the opposite arm bends up at the elbow.
See, he's going on guard. And that's how that works.
This reflex lasts until the baby's about 5 to 7 months old.
Not entirely sure the practical why they do that, but it's kind of cool. And we're going to do Babinski, and that is something you've also seen in clinical.
Testing the Babinski reflex in infants. The Babinski reflex can be tested in infants by firmly stroking the sole of the foot with a finger or a blunt object along the lateral side from the heel to the toes.
There they go. Okay.
Typically in infants, a tonic dorsiflexion of...
And let's go to the stepping reflex, another one that parents like.
Stepping reflex. This reflex is also called the walking or dance reflex because a baby appears to take a step or dance when held upright with his or her feet touching the solid surface.
There it goes. Okay.
This reflex lasts about 2 months.
Okay. So those are some different reflexes that we look for in babies, and they're totally normal. Oh, sorry about that. Let's go back to presenting. Okay. And next slide. All right. So then we look at the skin. The skin is the biggest organ in the body, and it's not very different from assessing an adult in terms of the first thing we look at is color. So what we want is this baby here. He's nice and pink, although his hands are blue and his feet are blue. That is called acrocyanosis, and as we learned in the last video, it is totally normal for the first few hours after birth. But he is pink in the middle. He's pink around his mouth. That's all good. This baby is not a baby who's behaving well. Probably wasn't a very good fetus either. He's that purple shade of eggplant, and you see all the resuscitation equipment there. So he's cyanotic. So we look at color. And here's a baby who's jaundiced. We look at the skin and we look for jaundice. Then there are some other color changes you might see. These are sort of variations that are not typical for every baby, but they can happen and they're mostly normal. Modeling. Very early on, there's vasomotor changes as the baby's switching over from fetal to extrauterine circulation. You may see some modeling, but if you see it after the initial, once they start getting pink, if you see this again, it could be from being cold or stressed or even sepsis. So, we could tolerate it right at delivery, maybe for a little bit. You don't see a lot, but if you were to see it then, there are vasomotor changes happening. If you see it later, it's an issue. This here is called the Harlequin sign, and it's, again, not something we see a whole lot of, or not something I've seen a whole lot of. Maybe other people have. So I'll qualify that, but it's like one half of the body is red and the other half is sort of normal flesh color. And that's also vasomotor changes. And, if it doesn't persist, usually it just resolves. But it's a variation of normal. Other things we look at in the skin, here's your baby who's maybe earlier, 37 weeks, I'm going to guess, 36 weeks, either a late preterm or an early term baby because there's lots and lots and lots of vernix. And then here's your post-dates baby. Remember I said they're leathery and cracked? Well, there it is. They look like they've been overcooked. They dried out in utero. Other things we look for in the skin, we look for bruising. This baby has facial bruising. Now, you might look at this baby and think maybe it's cyanosis. And maybe, this is a cue to sort of assess a little bit further. But facial bruising is common and it can look like cyanosis. And one of the keys is you would blanch it and see, what color is underneath. Also look at the lips, the tongue, the gums, look at the central, and observe for other cues. But bruising is common after delivery and should be noted. And it should be passed off in report so that people don't get scared. If they see a baby that's got some facial bruising, they're not thinking the baby's cyanotic. But you would assess that carefully and make sure the baby is in fact bruised and not cyanotic by looking at the mucous membranes, by observing the baby breathing. You might even check a pulse ox if you're really worried about it. Nothing wrong with that. And you can always call in somebody who's more experienced than you if you're not sure. Here are forceps marks. So you would assess those and note them. They mostly go away. Here is the mark. It's like a little abrasion of the scalp where a vacuum was applied. And if we know there was a vacuum and we see that, we would note it so that people could monitor any changes in it. You might apply some bacitracin. Other things we can look at in the skin. Here's some meconium staining of the umbilical cord. That means baby was exposed to, they had their first bowel movement in utero and they were exposed to that meconium fluid. And here's vernix that's stained with meconium. So we would note the presence of that. Lanugo, we talked about this with the preterm baby. So this is that hairy kid. Hairy shoulders, hairy arms, hairy back. If you turn him over, you probably see it on the forehead. And that's a sign of usually early babies. Then we can look for lots of normal stuff. These are stork bites. They are totally normal. There is a formal name for them. I'm not going to worry about it too much. Telangiectasis nevi. But other people call them angel kisses, and they're really cute. They usually appear on the eyelids and the nape of the neck, sometimes between the eyebrows. These little white yellowish dots are called milia, also normal. They are a result of exposure to mom's hormones and the baby's skin being sensitive, and they will go away. Rest assured. These are Mongolian spots, totally normal. In most babies of color, you will find them, and in some Caucasian babies as well. They should just be noted. They are not bruises. They will disappear by about 3 years of age, somewhere in the preschool years. Cafe au lait spots, again, totally normal, look kind of like a freckle. Now, if you have 9 or more, have a pediatrician evaluate. It is a sort of a soft marker for neurofibromatosis, but there have to be kind of a lot of them to raise suspicion. Now, this is not a newborn. This is an older child. I had a hard time finding a congenital pigmented nevus on a newborn that was not totally covering the baby's body. I guess those were the pictures that got photographers' attention. But these are sort of normal changes. They may not go away. And in some babies, they should be watched for, some kids, when you have moles, you should always watch them for changes related to skin cancer. This is a nevus vasculosis or a strawberry hemangioma or strawberry mark. These are very common, usually appear on the head and face. They should disappear by the age of 5. Some parents get really freaked out by them. They will turn silvery white first and then they'll disappear. But unless they're obstructing vision, we don't advise removal because that can cause scarring, whereas the hemangioma itself will disappear, usually. This is a port wine stain, and you may have seen adults with port wine stains. They do not go away, the nevus flammeus. And this can be very distressing to patients, particularly in a culture where we put a lot of emphasis on personal appearance. It's important to stress to parents all the positive things about that baby. Because that port wine stain can be distressing to parents. It's really of no clinical significance. Then we have good old newborn rash or erythema toxicum. And even in the name, the formal name, it sounds like it should be something really horrible. I mean, it looks like an infection, but it's not. It's just normal. Um, as opposed to some of these lesions, which are clearly not normal. This is a herpes, congenital herpes infection, and you see those fluid filled vesicles. This child is highly contagious and may even get septic from this. So when you see fluid filled vesicles, that's something that we would want to be really, really careful with. And you would want your neonatologist to come consult. Probably that baby would have to be on isolation in neonatology. We'd want cultures and we'd want to start treating them. And this is varicella, congenital varicella or chickenpox. And you can see again, it's very different from erythema toxicum. It's not a newborn rash at all. This is serious and can have more. It's more than just skin deep. So that's skin assessment. We're on to the head. So we've all felt a lot of babies' heads. Now, just a word. Babies' heads look awful after a vaginal delivery. And this is one of those things that we kind of wonder why mom has such an adjustment in that taking in phase. Her fantasy baby didn't look anything like most newborns who look very, very weird. So when you assess the head, you're going to talk to mom and reassure her that most things are normal. You're feeling for fontanelles. Now here's the anterior fontanelle. You can see it's kind of diamond shaped. Not an exact diamond, but it's kind of diamond shaped and it's large and it's towards the front of the crown of the head. Okay, it should feel level, should not feel bulging, should not feel sunken. It will close at about 18 months of age. You'll learn more about that in peds. Here's the posterior fontanelle, and it's more of a triangle shape. Some kids have a bigger one, some kids have a smaller one. It is smaller. It will close by 3 to 4 months of age, and it's towards the back. Now, when you're palpating the fontanelles, you may feel the bones overlapping, and those are called overriding sutures. It's a normal finding. It's nothing you need to be concerned about. Now, here's what's not normal. If you have a fontanelle, and I'm not sure if you can see this really well, but there's like an indentation here. That is a sunken fontanelle. That child is dehydrated. And so, we worry about ineffective breastfeeding or mom who needs a little more education, or maybe the baby has a virus and is vomiting. So it's kind of a good thing that before kids are verbal enough to talk to you, they have they have the anterior fontanelle. So when they get, vomiting or something like that, we can sort of assess hydration status really well. Now, this is a bulging fontanelle. This kid has a syndrome. And part of that syndrome means that there's fluid on the brain. And that's what a bulging fontanelle means. So it's important to assess fontanelles. Now, for the weird stuff that is totally normal, molding, they all look like they don't all look like little cone heads, but a lot of babies do. They're not doomed to wearing hats forever, but that molding is normal. It just means they were in the birth canal for a while and their heads conform to that shape so they could fit better. Here is Caput. Caput is a little different. Molding, you'll feel the bones underneath the skin. And everything's just longer. Caput is swelling or fluid that collects under the skin, and it crosses the suture lines. Okay, so it's just diffuse swelling. It doesn't have a border. Doesn't have a boundary. It just feels like swelling, as opposed to cephalhematoma. And you notice it's like a goose egg that's on one side, does not cross the suture lines. Here's a suture line right here. Here's your bump right here. This is a small collection of blood, not to be alarmed. People see the word hematoma or they hear that there's a collection of blood and they get nervous. It's just under the scalp. The scalp is very vascular. And sometimes during a delivery, depending on which way the baby was coming down against the bones, or if there was a vacuum or something like that applied, you may have this little cephalhematoma. The only clinical significance to this, it usually goes away in a week or two. The clinical significance is that as it's going away, those red blood cells are breaking down. They're releasing some bilirubin. So the kid's at a little higher risk for jaundice. We watch all kids for jaundice. So anyway. Okay, so then we're going to look at the face. So this baby is crying. This is a good time to assess the face. What you're looking for is symmetrical movement. So when the baby cries, both sides of the face should move equally. If they do not, we worry about facial palsies or facial nerve damage, and that can happen sometimes as a result of position during pushing, or it can happen as a result of forceps delivery. Most cases will resolve in a few days. but it can cause problems with feeding if the baby doesn't have good motor function on both sides of its face, obviously. Now, this one here is totally not normal. This is what they call micrognothia, or recessed jaw. And this is usually part of a syndrome. And so this baby would have extreme difficulty feeding, swallowing, and would need to be watched in the NICU. So you look at your face, you look for normal features. Other things in the face, the eyes. This is a nice normal eye. The sclera are nice and white. There's a pupil. Looks like the eyes are very dark gray. On the other hand, this baby here, not so normal. Let's get a pointer on that. This is a baby with gonorrhea infection in the eyes. This is one of the reasons we treat with erythromycin ointment. You see that yellow goopy discharge coming from the eye. It can lead to blindness if we don't treat it. Here in this slide, you have a subconjunctival hemorrhage. Not really that alarming. It happens with pushing and it goes away in a week or two. And then here's some eyelid edema. And this is something I just wanted to call your attention to. Most babies are fairly edematous in their eyes. So we're going to have to do what this examiner here did, although I would be wearing gloves while I was doing it, is we might have to pry that eyelid open and make sure that there's actually an eyeball there. Believe it or not, in my career, there have been 2 babies born with a congenital absence of the eyeball. And they were both, I think, they both had syndromes. One of them had trisomy 18, and I couldn't tell you what the other one was. But you want to make sure that there is an eye, and you want to make sure that it's a normal eye. So you're going to pry those eyelids open. Now we're going to look at ears. Ears are important. You know why ears are important? Because ears develop at the same time as kidneys. And we can see ears, but we can't see kidneys from the outside. So we want to look very carefully. Most of the things you see in the ears, even if they look freaky, like these skin tags here, don't correlate to kidney damage, but it's just one of those little red flags that come up. So we look for pits, we look for dimples. Here's a little sinus right here. It's almost hard to see, but that's why we have to be really good detectives and look at everything. Sometimes these little holes can also lead to, if they go all the way to the cranial nerve number 8, they can signify some kind of hearing loss or hearing damage. So we want to note these, and we want to let the pediatrician know so that they can do a careful assessment. Now, this baby here has low set ears. You measure the ears by trying to make them level with the inner canthus of the eye. And you see that, like, if I go straight from the inner canthus of the eye back, these ears are lower than that. He also has a recessed jaw. And this is a baby with a syndrome. But low set ears are a marker for different syndromes. Like you'll see it with trisomies a lot. Pierre Robin, I think, is another one. But that's more for peds content. And we're going to look at the mouth. Good night, honey. We're going to look at the mouth. We're going to look in the inside. This is a nice normal kid with nice pink, moist mucous membranes, tongue, gums. I don't see anything unusual in that mouth. Here in this mouth, these are sort of variations of normal. They're not really ominous, but these are called Epstein's pearls. They almost look like teeth, and you'll get some people go, "Oh, does my baby have teeth already?" No, they're little cysts, and they're in the gum, and they go away. But we note them, the presence of them. Here we have that baby with the tongue tie or the tight frenulum, and that's something that maybe we want to refer to the pediatrician for a frenulotomy so that the baby can breastfeed more effectively. And then we see some other variations with the mouth. Here we have circumoral cyanosis. Now, generally, when a baby starts to decompensate, if it's a heart problem or a respiratory problem, they'll get blue around the mouth. Now, we saw some facial bruising earlier, but the difference is if you were to open this baby's mouth, he would also be cyanotic. And you can see some cyanosis in the lips and pallor in the lips. And you would also correlate with other clinical signs. Now, the clefts, facial clefts. We have cleft palate. This is another good one that you need to do when the baby's mouth is wide open and crying, and you need good lighting to do it. Sometimes, like this baby has a big dramatic horseshoe. Some babies actually only have a little slit, but this can lead to aspiration with feeding because there's like an opening, an abnormal communication between the trachea and the esophagus. So we would want to note that it's present. A lot of times you'll take a gloved finger while you're assessing the baby's suck, and you kind of feel all the way back to the soft palate. Some clefts extend from the hard all the way to the soft. Some only affect the soft palate, but it's important to assess for that because otherwise we can have aspiration. This is a cleft lip. Cleft lips are obvious. You will not miss a cleft lip. If it's there, you'll see it. And sometimes you'll get the information ahead of time from ultrasound findings if the baby has a facial cleft. So moving on from the head and face, we go down to the clavicles. And here I could not find a good picture of palpating clavicles, but you're going to run your fingers gently along this surface. And you're going to do it on both sides. And what you're hoping to not find is something that feels like bubbles popping or feels like a grating sensation or a sensation of movement. Those clavicles could be really solid. If you feel that stuff, it's called crepitus, and you stop palpating and refer to somebody who can help you. So the thing is, you have these bone fragments, and think about where the lung is. It's right here. You can actually cause a pneumothorax if you drive this bone fragment into the lung. So once you elicit crepitus, stop feeling it and get someone else. You're also going to look and see if the baby's moving both sides of its arms. And that's what this picture here was intended to show. So if you have a baby who had a shoulder dystocia, and it's really something you assess on every baby, but you're more suspicious with the shoulders. You'll see this baby is flexed on one side and this arm's kind of hanging. So look for symmetrical movement. Make sure that the baby's moving both upper extremities, because that can be another sign of fractured clavicle or nerve damage to the brachial plexus. So we want to be careful with that. Sometimes in a shoulder dystocia, the brachial plexus is a bundle of nerves in the upper extremity. It gets stretched. Sometimes that damage is temporary and sometimes it's not. Now that we're talking about upper extremities, let's move down to the hand. Look at that lovely, perfect little hand. It's got 1, 2, 3, 4, 5 fingers, and none of them are fused together or webbed. What we can see in the abnormal pictures is something, this is called syndactyly, and these fingers are fused together. And that happens pretty early in embryonic development and needs some kind of correction. Some syndactylies are much more serious than this. You can see all of the fingers fused together. Sometimes fingers are missing. But that's syndactyly. Now, polydactyly is actually pretty common and it runs in families. It's a recessive gene. And sometimes they look just like these little nubbins. Sometimes they're like bigger and they're dangly. And sometimes they're like full-blown fingers. And the correction for that's going to vary. If it's one of these guys or something that's dangling by a little skin tag, usually they'll just take a piece of suture material, tie it off, and that lack of blood flow will cause it to fall off, and you'll find it in the crib at some point. Some nurses get really freaked out about this. Most parents, if they know it runs in their families, are not as freaked out as the nurses are. But that's usually not as significant as like syndactyly is worse. And then we have, we're going to look at the creases in the hand. Now here, if you look at your own hand, most of you never know, maybe I'll find some of you that have a simian crease. Most of you have these two creases. There's this one on top and this one on bottom. If you were to read someone's palm, if you believed in that nonsense, the lifeline, the love line, but it should have two distinct lines going across the palm. In some babies, we have what's called a simian crease. And it's called a simian crease because primates, monkeys, apes, have one crease that goes straight across. This is a marker for Down syndrome and other developmental disabilities. So if we note it, we want to make sure that we're looking for other signs and that we're alerting the pediatrician that the baby has simian creases. Now, if they're bilateral, that's a much stronger marker. I have seen one baby who had a simian crease on the left and not on the right, and he was perfectly normal. But it's something we look at. So for a respiratory assessment in the chest, we're moving down the baby. We're doing our systematic head to toe. We're going to listen to breath sounds. And just like in the adult, should be clear and equal. I'm going to show you the video right now of what a respiratory assessment looks like. He's using a really big stethoscope. And that's okay. He's at least using the diaphragm, which is the correct side. The bell is for low-pitched sounds like heart murmurs.
Okay, I need to listen to
but
her lungs.
anterior, and then the axillary, and then posterior. Now, if your baby's not really showing any signs of respiratory distress, you don't really expect
I know.
too much crazy stuff in their lungs.
And as I expected, her breathing was perfectly fine. Okay, honey.
And if you replay that video, and I will for a second, you'll actually hear the breath sounds.
So now we're going to listen to her lungs.
Okay, so you got to hear some of those breath sounds. If not, put on headphones or turn down your volume and listen. So when we look at the chest with breathing, obviously, movement should be symmetrical. You don't want to see one side working harder than the other. You don't want to see those seesaw respirations. You're going to look at the contour of the chest. It should be cylindric. It should look like a normal, healthy baby. If it looks like it's caved in, as in pescus excavatus, or Pecatoris excavatus. There's a fancy Latin name for it. Don't worry about it. If you were to see a baby that did not appear normal, if it looked like the chest was caved in, you would, of course, note that and look for signs and symptoms of respiratory distress. Babies are periodic abdominal breathers, so that's okay if you see that. We're going to look for contour, symmetrical movement. Some babies, you can see the xiphoid cartilage. It'll be right about here. As they get fatter, that gets covered up. Breast tissue, as we noted in the Ballard, increases with maturity. And here this baby has an accessory nipple right there. It's really of no clinical significance, usually in line with the milk, what they call the milk line. Now, while we're on the chest, let's assess the heart and circulation. When we get to class, I'm going to play some sounds for you. We're going to listen with both the bell and the diaphragm, and it really helps to have a newborn stethoscope when you do this assessment because sound is poorly localized in a baby. If you put a great big diaphragm down on a baby, you're going to hear sounds referred from everywhere. You'll be listening to lungs, bowels, and heart all at the same time. And when you're listening for the heart, you really want to be assessing not just for the rate and the rhythm, but also for the presence of murmurs, which are super common in newborns. The rate should be regular, 110 to 160. You're going to go in about the same direction as you would for an adult, except that the heart in the newborn is smaller, so it's less surface area. So we're going to go from the right sternal border here, and that's your aortic valve. Then here's pulmonic. And then here you have tricuspid, and then here's the mitral. And usually get a heart rate really well right around here. Murmurs, as I said, super, super common in babies. I hear them a lot. When you get really good at listening to babies, when you've listened to a lot of hearts, it sort of sounds in a normal kid with maybe the PDA, the ductus arteriosus, and the foramen ovale, those little openings. I did not beat this to death because I think it's something that confuses students a lot. But you have those valves or those openings to sort of bypass the lungs. And when the baby starts breathing air, the surface tension changes and those valves close, but they don't always close immediately. They don't slap shut. So the ductus arteriosus could take like a day, and the foramen ovale could take, 1 to 2 days. So you might hear this murmur at birth, and by the time the baby's discharged, it's gone. Some babies, it takes a little longer. But you'll hear it sort of sounds like a washing machine. It's a soft swishing sound. Now, if you hear something different, if you hear a grinding sound like something got caught in a garbage disposal or caught in the washing machine, that would require further investigation. And of course, you're going to corroborate with any signs that that baby's compromised. So you're looking at things like tone. A baby who is not getting good oxygenation is going to have poor tone. They're going to have poor color. They may look dusky or gray. They may turn blue in a cyanotic heart defect. Look for feeding. So maybe 3 or 4 times in my career, I've had a baby that surprised us with an unknown issue, whether it was a heart defect or bleeding in the brain or a metabolic defect. But the key thing to all of them is that they would not eat. Now, I'm not talking about your punky breastfeeders who can't manage latch. I'm not talking about babies that need to be woken up for feedings. And I'm not talking about babies that don't, suck continuously for 45 minutes. I'm talking about a baby. If you put a gloved finger in their mouth, you cannot elicit a suck reflex. You put a bottle in their mouth, and even though it's kind of dripping out of the nipple, they will not eat. They will not suck on that bottle Bad feeders are bad babies. Remember that always. I've had 2 babies that were shipped out. One went on a transplant list. The other one had tetralogy of flow, and they were both babies that just never fed well. One with a brain bleed, grade 4 in the left. So you're going to look for cry. If you're concerned, you hear a murmur, you're not sure, you can put a pulse ox on the baby, put it on the right hand, and you'll get what's called preductal or before the ductus arteriosus. So more on the heart and circulation, we assess pulses. In a baby, we generally assess brachial, femoral, and you can assess pedal. We don't usually go for radial. You never go for carotid because, look, he has no neck. But you would assess the brachial right about here. I usually actually get it right about there. And I palpate the brachial at the same time as the femoral. And I have my reasoning for that is that some babies have what's called coarctation of the aorta, which you'll learn more about in peds. But the telltale sign is you got a big bounding pulse up here and a weak or absent pulse down here. And the extremities will reflect that in their color. Abdomen. Normal abdomen, soft and slightly rounded, just like this baby here. Look for distension because that's the first sign of trouble, and it usually accumulates over time. And I'll show you a picture of a distended abdomen in a little bit. You are going to look at the umbilical cord and make sure that it has 3 vessels. Some babies have 2 vessels, and most of the time that's known to us from ultrasound, but you're still going to look for that smiley face. The 2 arteries in one vein, AVA or AVA, and the arteries look like little eyes, and the vein is this big floppy smile. So look for that happy face on the umbilical cord. And we're going to listen for bowel sounds in all 4 quadrants. What I do not like about this picture is, number one, he's not really in a quadrant. He's sort of smack in the middle. And also he's using the bell. And that's inappropriate. Yes, the bell is smaller and the baby is smaller, but that does not mean that the bell is the appropriate place or the appropriate equipment for that. You really need the diaphragm to listen for the higher pitch sounds. Some variations you might see, and they're kind of okay, unless they're not. This is a diastasis recti. This just means the baby's muscles are not all the way fused. That usually disappears. And then we have, this is the linea nigra right here. Very similar to mom, and it all comes from mom's hormones. That also disappears. Here's an umbilical hernia. Now, it's more common in African American babies and Hispanic babies, but it can happen in Caucasian babies. And it's just where that, maybe that muscle line, that rectus abdominis is not that strong. You have some poking out of the abdominal contents through that umbilical opening. Most cases will resolve by the time the baby's in preschool. We worry sometimes about incarceration of a hernia if that abdominal wall starts to close on intestinal contents. It's rare, but it can happen. Some cultures will put a coin and wrap it really tight around this. That's a place where, although we like to be culturally sensitive, we want to keep our babies safe, so we discourage that. Abdominal distension, here it is. That's why it's important to get a good abdominal circumference early in the beginning, because if a baby has issues, they have some kind of intestinal blockage or some GI issue, the first thing that's going to happen is their belly's going to fill up like this. And that is an indication that you need to make a phone call and get that baby some help. Next, we're going to talk about hips. So a common problem in newborns is congenital hip dysplasia. It's not terribly common, but it does happen. It's more common in girls because their pelvis is a little wider and the angles are different. It's more common in your breech babies they just liked sitting crisscross applesauce when they were inside mom, and all that pressure from contractions kind of pushed down on that crisscross applesauce hip joint. And it's more common in families that have congenital hip dysplasia. The way that we assess for it, there's a couple ways. We have some maneuvers. We have Ortolanis and Barlows, which I'm going to show you in a second. And then we look at the length of the legs and we line up the creases and make sure everything's symmetrical. So here is it's the best I could find.
How to test for newborn hip dysplasia by Dr. Nina Gold.
Little plug for quick concepts.
We will now assess the infant's hips to test for hip dysplasia. Hip dysplasia is a congenital deformation or misalignment of the hip joint and is more common in infants who have a family history of hip dysplasia, are female, or who had a breech presentation in utero. Assess the hips one at a time using 2 maneuvers. In the Barlow maneuver, first adduct the hip by bringing the thigh toward the midline. Then apply a gentle posterior pressure to the knee. In the Ortolani maneuver, flex the infant's knees to a 90-degree position, then abduct the legs by folding the thigh outwards.
Okay, so what would be an abnormal finding with an Ortolani's or Barlow's maneuvers? Because she really didn't say anything about that, but you would feel that joint slide past that ball and socket. And you would describe it either as a click, which is sort of a partial dislocation, or a clunk, which means that like it really falls out of that ball and socket. If you assess that and it does not feel normal to you, you need to refer to the pediatrician. They will repeat your Ortolani and Barlow's maneuvers, and they'll probably order a hip ultrasound. It may happen outpatient. It's not considered an emergency. And the treatment for it is either a Pavlik harness, which you'll see in peds, or sometimes they'll just say to use 2 diapers instead of 1 and kind of support it. Depends on the degree of the hip dysplasia. Now we're going to look at external genitalia. We're almost at the end here, guys, and I can't believe that I have to put this disclaimer on, but it's a sick world we live in. This is for educational purposes only. You naughty people, stop looking at baby girl parts. We are going to check the labia majora, which are here. This is obviously a term baby because we really can't see the labia minora without spreading the labia majora. So that's a term baby, but not post-term because there's vernix here. And you can look for the clitoris. Now, what's important about this is that sometimes babies have ambiguous genitalia, and it can be hard to tell whether what we're looking at is an over-enlarged clitoris with labia majora that are swollen, look like a scrotum, or whether we're looking at a micropenis, a very small penis, where the scrotum is sort of underdeveloped and the testes are not descended. So it's important to really inspect these parts and make sure that they follow one pattern or the other. And if they don't, all is not lost. We refer to the pediatrician and it gets handled that way. And I have a story for that, but I'll share that in class. Mucoid discharge in a girl is normal. Normal. Mom will go, what is that stuff? And they try to wipe it. You really don't have to go nuts with it. It is from mom's hormones. Mom is donating lots and lots of estrogen, progesterone, and then they drop. And the baby experiences that drop as well, which becomes more dramatic when we clamp the cord and cut it. Pseudomenstruation or a drop of blood in the diaper is also normal. Now we have boys. Again, educational purposes only. If you are here for any other reason, please leave my spot. Don't want you here because that's sick. You're going to check the penis and make sure that it is relatively normal. We'll look at some variations. You're going to look at the scrotum. And there we're going to look at the rugae and the just overall development, and we're going to look at testicles. And for that, we want to check descent. Now, I don't particularly care for the way this guy's doing it. The way that I normally do it is I put my non-dominant hand in one spot to kind of anchor the testicles down. So I just put very gentle pressure right here, right below where the bladder is, and right above the scrotum. And I feel for the presence of a small, soft, smooth testicle ball right there. And then I do the same on the other side. Undescended testicles are common in preterm infants. If they do not descend, they stay inside the baby's abdominal contents. And that's a problem because the testes need a cooler temperature in order to be able to produce sperm. And so they need to descend. Sometimes you'll find that the left is last, so you'll feel the right testicle, but not the left. Sometimes it's in the inguinal canal, but if we don't find both testicles, we refer to the pediatrician and we anticipate orders for an ultrasound to see where those testicles are. We also look at the urethral meatus. It should be central. We should be able to easily visualize it by gently retracting just a little bit of that foreskin. There are variations, and these are not normal variations. These are things that require correction. We have hypospadias here in this picture, and that is when the urethral meatus, excuse me for kind of not saying the fancy words that well, is on the dorsal side of the penis. So there's an urethral opening here, somewhere on the shaft of the penis. Sometimes it's up a little bit higher, just under the glands or on the dorsal side of the glands, but it is not normal. And it's important to assess these. Epispadias is the opposite. It's like up top. Now, it can be somewhere on the shaft. It can be just under the glands. It can be on the top of the gland. So there's degrees of epispadias and hypospadias. What's important to know about them is that you should not let this baby be circumcised if they have an epispadias or hypospadias. They can eventually be circumcised, but because this needs to be repaired, because it results in altered urinary elimination and other problems, they can use some of that foreskin to repair that abnormal opening and create one a little bit higher up. So don't let the baby be circumcised until somebody has visualized that urinary meatus. Last, we're going to look at lower extremities. I think this is our last slide. And we're going to check, maybe second to last. Yeah, second to last. We're going to check, stretch the baby's legs out, and we make sure that they are the same length. Then we line up these little creases and folds. So the fold that's just underneath the buttocks, they should be in the same spot on both legs. And all of the other creases should really line up and be nice and symmetrical. If they're not, if one leg is shorter than the other, we worry about hip dysplasia because that means that somewhere the head of the femur is not in the acetabulum, that ball and socket joint, and we would want to maybe take a more careful look at that baby. We're also going to check the feet for club feet. We already talked about looking for creases in the foot, but we're going to look at the actual presentation of the feet. This is a baby who has a club foot, fancy name Talipes equinovarus. And sometimes this is a true defect, which means that the bones and joints formed abnormally, and that would require some kind of correction, either surgical or with orthopedic supports. Or it can just be positional. A baby got in a weird position in uterus and one or both feet sort of turn inward. And the way that you would check for that is you would try to gently use your hands to put those feet back into alignment. If you can't do it, then it probably is a true club foot. If you can put those feet in a normal position, they may not stay that way, but they will go back that way. That means that the bones and joints are normal. They just positionally got a little contracted in that shape, and it'll resolve as the pressure's resolved. Then, now, first glance, you might think this baby's feet are normal, but let's count 1, 2, 3, 4, 5, 6. 1, 2, 3, 4, 5, 6. We have polydactyly of the toes. Again, this is a recessive gene. These toes are like fully formed, but you can see them just like in the hands, little nubs or danglies, we call them. I call them, a lot of my friends call them that too. But, again, we would want to count the toes. And then here's syndactyly, and these toes are fused together. That can be more or less severe, where you have two toes fused together, or webbing. Sometimes it's just skin deep, where you have webbing between the toes. But you would note it, and you would refer that to a pediatrician. Just on a cute side note, all parents love to ask you, baby's like a minute old, and you're still doing APGAR scoring, and they're going, do you have all his fingers and toes? And you're like, no, I'm still on airway, breathing, and circulation, but yeah, I'll take a look. And it's one of the things that people count. It's like reassuring when it's normal, but it's not necessarily horrible if it's not in the case of polydactyly. Syndactyly is maybe a little bit more serious, but anyway, so in summary, a lot of things can go wrong in the process of making a new human, but mostly they don't. But be a good nurse and look for it anyway. And thank you and good night. See you in class.